Okay, so before we start our next topic, with last class ko alikati revision jastै एकचोटि हेर्ने. This is a case भन्दा नि direct question छ. So following a trans-Pacific flight from Australia, a 57-year-old man develops deep vein thrombosis in his right leg. He receives heparin to treat the deep vein, but after 6 days of the therapy, he develops heparin-induced thrombocytopenia, HIT, right? So what drug is he likely to receive instead of heparin? So what do you think among these 4 options? Kun चाहिँ होला? Argatroban, warfarin, dabigatran, rivaroxaban. What is the alternative drug for HIT? याद छ कसैलाई? Anyone? Try.
Argatroban.
Argatroban, yes. Right? What is argatroban? के argatroban भनेको?
Penicillin, parenteral direct thrombin inhibitor.
Yes, parenteral direct thrombin inhibitor. So, these are warfarin, dabigatran, these are all oral anticoagulants. So, the alternative to heparin would be argatroban. This is also the parenteral, and this is a direct thrombin inhibitor, whereas heparin is indirect thrombin inhibitor. The second question. It's a very straightforward question again. The apixaban when it drugs. So see, a 52-year-old woman with atrial fibrillation, the atrial fibrillation was prescribed apixaban. What is the mechanism of action of this oral anticoagulant? के होला apixaban भनेको? यो मैले डिटेलमा त भनेको छैन तर पनि still. What is apixaban? कुनसँग मिल्छ होला?
X inhibitor.
Yes. Yes. It directly inhibits factor factor 10A. So it is the drug similar to this rivaroxaban. Okay, just the last class revision. Okay, let's start with. Okay, we'll be talking about the antiplatelet drugs today. So a brief physiology again of this primary hemostasis. So we have briefly discussed about this, how the primary hemostasis occurs, right? The first platelet plug formation, right? So there was 3A, adherence, activation, and aggregation, right? So here, few things that few of the molecules we should be knowing, because this will will be the target of the drugs that we'll be discussing. All right. So this is the first step, the adhesion. So collagen, once the collagen and von Willebrand factors are upon upon the vessel injury, once these proteins get exposed, let's say some platelets, they will be attracted to it, right? So that is adherence. So once there is adherence, you can see, and then there will be activation. So activation on the in the last picture, we have seen that there is shape changes in the platelets, right? And those shape changes, or you can say the activations, receptors are inside. So these are the receptors through which it binds to the collagen and the BWF, right? And then there will be activation, and that activation lead to release of these vesicles, let's say, all right, or the granules, right, that will be released, and those released molecules, they are called aggregatory molecules, right? And that can include the ADP, can be thromboxane A2 and serotonin. So aggregatory mediators are, right? And we have the drugs that targets the ADP, that targets the action of ADP and this thromboxane A2, not this of serotonin. We don't have drugs available drugs does not target the serotonin, but we have the thromboxane A2 inhibitor like aspirin and then ADP inhibitors or cyclopidine. They are the target of these aggregatory mediators, right? Now, so normally, so the aggregatory mediators, they will attract the other platelets, right? And other platelets, they will be attracted, right? And they will again be attached to each other, right? Through another receptor called glycoprotein 2B3 receptors, right? So these receptors, it helps attach the two or more platelets, right? And also to the fibrin, right? So fibrin attachment so that the blood clots are formed, and alongside you can see the coagulation cascade, right? So these platelet block formation, you can say this 2B3 receptor activation, right, will be the final step of platelet aggregation, right? So we have the drugs targeting this receptor as well, right? So let's see, we have very less drug here, right? Antiplatelet drugs there is, and it's very easy also. So we have 4 classes of drugs: thromboxane A2 inhibitors, right? Or you can say these are the thromboxane A2 synthesis inhibitor, right? So we have aspirin, mainly aspirin only. Phosphodiesterase inhibitor like dipyridamole, ADP receptor inhibitors like ticlopidine, clopidogrel, and prasugrel, and lastly glycoprotein 2B3A receptor antagonist, in which we have the antibodies mainly like afliximab, eftifibatide, and tirofiban, right? So aspirin, you all know the mechanism of action of aspirin, you have already finished in your MSK block, right? That it inhibits the COX enzyme, right? And same mechanism applies here as well, of course, right? So you know that so COX enzyme inhibition, all the prostaglandin synthesis will be inhibited, of course, right? But aspirin ko ESMA will, as an antiplatelet effect, will mainly focus on the thromboxane A2 synthesis, right? So because aspirin, it inhibits the COX enzyme, both 1 and 2, it inhibits the synthesis of thromboxane A2 as well, right? But the thing that you should be remembering is that thromboxane A2, this is the major secretion of the platelets, right? So among the other prostaglandins, this would be the major secretion, and that's why the antiplatelet effect of these aspirin or NSAIDs occurs, right? Plus prostacyclin, right? Prostacyclin is also there, which is PCI2. This is the major secretion of endothelial cells, vascular endothelial cells. But the effect is just the opposite. Thromboxane A2 is an aggregator mediator, whereas prostacyclin is an anti-aggregator mediator, right? Mechanism of action, it inhibits the COX enzyme and inhibits the synthesis of the decreased production of thromboxane A2, right? And hence it prevents a platelet aggregation, because now we know that thromboxane A2 is an aggregatory mediator, right? So decrease in synthesis of thromboxane A2 means decrease in platelet aggregation, right? As well as it also causes vasoconstriction, right? So it is just a part of the prevention of blood bleeding, right? Vasoconstriction prevents the blood flow. Besides that, aspirin also inhibits the release of ADP. We'll come to this So aspirin also inhibits the release of ADP, which again by now you know that ADP is an aggregated mediator. So this is another way of preventing the platelet aggregation, right? So that's all the mechanism of action. The other NSAIDs, if you say the other NSAIDs, then this antiplatelet effect, because basically aspirin is an irreversible, irreversible COX inhibitor, isn't it? It acetylates the COX enzyme, and that's how it acts, right? But other NSAIDs, they don't act irreversibly, right? And this irreversible effect is important in case of antiplatelet, as an antiplatelet effect, right? That also will come across again. This is something we will discuss. So this is the thing, right? So low dose aspirin, right? Aspirin ko as a low dose aspirin, but not high dose, has antiplatelet effect, right? Now why high dose the antiplatelet effect can rather decrease, right? So why? Because thromboxane A2, Okay, because see, that low dose will usually be about 75 to 150 mg. All right, usually they keep below 100 mg. In fact, all right. So at this dose only, the aspirin it has the antiplatelet effect. Right now, why? Now there are few points that we will discuss. All right. So platelets they are exposed to aspirin in portal circulation before even it is diacetylated. Right. This is not much that important effect, but still, the platelets because yes, so platelets they cannot synthesize fresh enzymes. Okay, so platelets they are unnucleate cells, isn't it? So they don't have nucleus, right? And that inhibition lasts for the whole lifetime of the platelet. Okay, so the inhibition it lasts for the whole life of the platelet. That may be about 7 to 10 days. What is exactly? So I don't remember exactly, but it's around 7 to 10 or 12 days. All right. So that the inhibition will last for that period, right? And you see the platelets they are exposed to aspirin in portal circulation before even it is diacetylated. Means that effect before it is metabolized, before the drug even is metabolized, it will be exposed to the drug, right? And that effect will now be cumulative distance, right? So with low dose, low dose, you don't need to give a high dose for that inhibition, right? That amount of inhibition, isn't it? So with repeated dose, with repeated low dose of aspirin, that inhibition of that inhibition of the enzyme, all right, inhibition of that COX, it will be cumulative, right? Plus, another thing is that low dose aspirin therapy does not significantly impair the prostacyclin, this PCI2 prostacyclin that we just discussed. Okay, prostacyclin, which is present in the endothelial cell. Okay, so low dose aspirin therapy does not significantly impair prostacyclin synthesis by vascular endothelium, right? Because prostacyclin because there is a difference. Vascular cells platelets there is a difference. The difference is that platelets they are unnucleated cells, right? Once they are inhibited, the inhibition is for the whole lifetime, right? Whereas the endothelial cells, because they do contain the nucleus, right? So even if the COX is inhibited, they can synthesize other COX enzyme, isn't it? So that inhibition is not like prolonged in case of the vascular endothelium, right? So so low dose aspirin that inhibition is not significant for prostacyclin, right? But if you give the same in high dose, the inhibition of prostacyclin can occur, right? Okay, so platelets they do not contain nucleus, right? So inhibition will be for lifetime. Low dose aspirin prostacyclin synthesis is not significant. Prostacyclin inhibition is not significant, right? And prostacyclin, because it is anti-aggregatory, अब यसको सिन्थेसिस इनिबिट हुनुपर्ने हो कि नहुनुपर्ने हो त्यो याद गर्नु पर्यो. So thromboxane synthesis should be inhibited, right, in platelets, whereas prostacyclin synthesis if it should not be inhibited because prostacyclin actually has anti-aggregatory property, right? So if you give the drug in higher dose, the prostacyclin will also synthesis will also be inhibited. If it is given in high dose, prostacyclin synthesis will also be inhibited, and that that prostacyclin is anti-aggregated basically. It will decrease the effect of the aspirin induced antiplatelet effect. Understood, everyone? बुझेको हो यसमा केही कन्फ्युजन छ? Okay. So high dose दिँदाखेरि चाहिँ उल्टै because prostacyclin is anti-aggregatory, high dose दियो भने it will rather decrease the antiplatelet effect of the aspirin, right? So that is why low dose. Okay, this is important. Okay, use will do it in last slide. Okay. Now next talk is aspirin. You know the adverse effects. I don't need to discuss aspirin adverse effects and other uses because you have already finished in your MSK block. This is not important. Okay, dipyridamol. Now dipyridamol is actually an antiplatelet drug. If you remember from your CVS, okay, CVS भएको छैन, sorry, CVS हुन्छ त्यसमा हुन्छ. So it is actually an anti-anginal drug. You read in angina pectoris. So dipyridamol here, it mainly interferes with it actually is a phosphodiesterase inhibitor. Okay, phosphodiesterase, it is the enzyme which converts the CAMP or which degrades CAMP into 5-AMP, right? Now, the main role is for calcium, right? The dipyridamol, okay, dipyridamol inhibit गर्ने calcium ko role here, right? Because calcium, before that, remember the role of calcium, that calcium junyo, which I said that there is shape changes during activation, right? Shape changes during activation. There is the role of calcium, right? Shape change protein or contract shape change it actually helps in release of all those mediatory aggregatory mediator release it helps, right? So now there should be decrease or increase in calcium. There should be, for antiplatelet effect, the calcium should decrease, aggregatory mediator could release. So here you can see dipyridamol, it inhibits this phosphodiesterase enzyme. There is two mechanisms. Okay, so one is it inhibits phosphodiesterase enzyme, right? So phosphodiesterase enzyme inhibition bar, this CAMP, you can see here, CAMP cannot be degraded, isn't it? So this is how it degrades. So CAMP, there will be increase in CAMP level, right? Because its degradation is prevented. Increase in CMP will lead to decrease in calcium. You look at the difference than other cells, because usually what we have studied in, especially in muscle cells, that smooth muscle cells, that increase in CMP increases calcium, right? But here, increase in CMP decreases calcium level, and decrease in CMP decrease in calcium. Increase in CMP obviously decrease in calcium bio, right? Decrease in calcium means decrease in release of the platelet granules, right? Here I have mentioned few role of the calcium. So the main is this, of course. So platelet granules are released now. There won't be any aggregation, right? Similarly, these are other role of the calcium. Activation of thromboxane A2 synthesis means decrease in calcium. Thromboxane A2 synthesis will also be decreased. Similarly, the activation of 2B3 receptor is also inhibited, right? So main yaad garनुपर्ने चाहिँ यो है हामीले यहाँ, right? So this is one. Another is it also decreases this adenosine receptor activation. Sorry. Right? Okay, just see here. So this is adenosine receptor, right? So A2 receptor. So it also activates this receptor so that there is increase in ATP formation, right? This I'll see here. So it inhibits phosphodiesterase and or blocks uptake of the adenosine, right? So adenosine, so that A2 receptor picture ma. So uptake of adenosine is inhibited, means the ADP, more of adenosine will be available extracellularly so that they can act on the adenosine receptor and activate this pathway. Okay, so activate this pathway. So if there is activation of this pathway means increase in CMP again. Increase in CMP means again decrease in calcium, right? So anyhow you have to increase the CMP, and that's how it decreases the calcium, right? So there is two mechanism overall: inhibits phosphodiesterase and or blocks uptake of adenosine. Adenosine uptake is blocked. So increased extracellular concentration of adenosine, which acts at the adenosine receptor to stimulate the adenylyl cyclase pathway, that's CAMP pathway, isn't it? And the rest. Okay, so that will increase in CMP, decrease in calcium, and interferes with platelet aggregation. यहाँनिर अलिकति कन्फ्युजन हुन्छ यो अपटेक एडेनोसिन अपटेक चाहिँ ब्लक गरेर चाहिँ एक्स्ट्रा सेलुलर कन्सन्ट्रेसन इन्क्रिज हुन्छ भन्ने बुझ्नु पर्यो सो द्याट the adenylyl cyclase pathway is activated. Okay, that's the mechanism of action of diparacetamol. But diparacetamol, the antiplatelet effect is, you can say, not sufficient, you can say, or not that beneficial in all those coronary syndromes and all as an antiplatelet effect itself. So this is mainly used only in combination, right? Because diparacetamol induced bleedings will be decreased and antiplatelet effect is not so much reliable. Antiplatelet effect bleeding like adverse effect will also be less, especially in comparison with to other antiplatelet drugs. So it is mainly used in combination with other drugs so that it has additive effect with less bleeding adverse effect, right? Like with warfarin, these are commonly used to decrease the incidence of the thromboembolism in patients with prosthetic heart valves. Prosthetic heart valves are used this is one of the risk factors that increases the risk of thrombus formation, right? So along with warfarin is usually given drugs, and along with warfarin, diparacetamol can also be added, right? And similarly with aspirin also it has synergistic effect, and that can be used to lower the risk of stroke in patients with transient ischemic attacks, right? Transient ischemic attacks are like mini stroke भनेर बुझ्ने अहिलेलाई है. So you will तिमीहरूले पछि पढिहाल्छ तिमीहरूको उसमा. So transient ischemic attacks for now is like mini strokes which if occurs frequently can lead to major stroke, right? So stroke aspirin सँग दिँदाखेरि चाहिँ it decreases the risk of further stroke in patients with such disorder, right? TIA भन्ने. Okay, so mainly combination मा दिन्छ भन्ने बुझ्नु पर्यो है उसमा diparacetamol. Okay, next is ATP receptor inhibitors, right? Like ticlopidine, clopidogrel, or sisma. And now these are all thienopyridine derivatives, right? And the mechanism is mainly they alter the surface receptors on platelets, that is the ADP receptor one, and inhibits ADP-induced platelet aggregation. So ADP induced platelet aggregation inhibit gonadotropin. So there are two purinergic receptors actually, P2Y1 and P2Y12 one receptors. So, right, your ADP receptors are purinergic receptors, right? And there are two types, P2Y1 and P2Y12 receptors, right? Both of which are the G protein coupled receptors, right? And all the ATP receptor inhibitors are prodrugs. They have to be converted into the active form, right? Now, mechanism of action again is they bind to the mainly P2Y12 receptor. Some drugs, and so they mainly bind to P2Y12 type of the purinergic receptors, and they block adenylyl cyclase inhibition by ADP. So they block adenylyl cyclase inhibition by ADP. See, now we know the role of adenylyl cyclase here. Adenylyl cyclase activation CMP increase, CMP increase there will be decrease in the calcium, right? So ADP, how ADP act is they inhibit the adenylyl cyclase activation. Okay, that's how the aggregation occurs. ADP ADP, it inhibits the adenylyl cyclase, right? And adenylyl cyclase inhibit calcium will be decreased, and if calcium is decreased, CMP decrease, and if CMP decreases, calcium will increase, and that will help in release of the aggregator mediator. Now these drugs, they bind to the receptor to which ADP bind. Means now ADP induced blockade will be inhibited. Inhibition of inhibition भयो stimulation भनेको जस्तै अब ADP bind हुन पाएन भनेपछि adenylyl cyclase will be now activated, isn't it? Means increase in CMP occurs, and increase in CMP means decrease in calcium. Understood?
Yes, ma'am.
Confusion. So it's like inhibition of inhibition भनेपछि बुझिन्छ. Okay, so decrease calcium in platelets and prevent activation and activation. right? So that's how the ticlopidine, clopidogrel, and all these prasugrel are occurs. Ticlopidine, okay, these have all ticlopidine, all these drugs are still used, especially in combination with the aspirin, right? Aspirin is, of course, the prototype of the antiplatelet drugs. So not only of its class, but of the whole antiplatelet drugs. So aspirin is the most commonly used antiplatelet, and the other drugs are usually combined with these drugs, right? Ticlopidine causes synergistic effect. So synergistic in the sense the all the antiplatelet drugs having different mechanism of action. If they are used in combination, they will have synergistic. Okay. So kinetics, there is kinetic difference in all these ticlopidine, clopidogrel, or prasugrel. So pharmacokinetic variations are there, right? So good oral absorption for ticlopidine. Food interferes with absorption and see converted in liver to its active metabolite. This is important because this is a prodrug. It has to be converted, right? Extensive plasma protein bound. Okay, plasma half-life is around 8 hours. Okay, now adverse effects, say alikati in compared to the clopidogrel and prasugrel, the adverse effects with ticlopidine is a bit more, right? So the most common adverse effects are diarrhea, right? Diarrhea, vomiting can occur. There are other serious adverse effects like bleeding, of course, bleeding, bleeding, neutropenia can occur, and even thrombocytopenia can occur. So these also require blood monitoring, right? And more seriously, in around like 1% of the patients taking the drug, leukopenia can occur, right? So even WBC count should be monitored frequently, right? So these are different adverse effects of ticlopidine. And another important, okay, serious adverse effects is thrombocytopenic purpura, right? This is it is a special, it is an like emergency conditions. It is related with the skin, purplish color skin, and then pigmentation, right? And thrombocytopenia is of course there, right? So this can be severe, right? So ticlopidine induced TTP can be severe, and this is the reason, right? TTP plus all those leukopenia, neutropenia, what I say. Usually nowadays ticlopidine is mainly kept as a last choice. So clopidogrel and prasugrel, they are more preferred over ticlopidine, right? So ticlopidine actually is the first of the class, but because of the so and so adverse effects, we have the other better drugs like clopidogrel, which have similar mechanism of action as well as even efficacy, right? And these are also given orally. So the thing is, these are safer and better tolerated, right? See, neutropenia, they can occur, but the frequency is lower than that with the ticlopidine, right? Even thrombocytopenic purpura can also occur, but again, it's less. Leukopenia is not there, right? So the safety profile, clopidogrel is preferred over the ticlopidine, right? So there's a bit of the drug interaction, right? They inhibit the CYP450 enzyme and can interfere with the metabolism of drugs such as phenytoin, tolbutamide, warfarin, and tamoxifen. Phenytoin is an anti-epileptic drug. Tolbutamide is a hypoglycemic drug, right? And then this tamoxifen, when uh, it's a drug that you read in your USMA. This is the drug used in breast cancer, right? So anyway, this drug inhibits the metabolism of these drugs, and in fact, phenytoin toxicity has been seen in both. You say this is for both ticlopidine as well as clopidogrel. There is drug interaction. Prasugrelma, there is only few things याद रखने that prasugrel is very active drug again, right? Rapid and complete absorption, sir. Most potent of all the drug. It can act, it has rapid onset of action, that antiplatelet effect is very quick, but there is always the risk of more bleeding. Or adverse effects are less in compared to the ticlopidine. The risk of bleeding is more actually. It was like known later that the risk of bleeding is more in compared to the ticlopidine as well as clopidogrel, right? So these drugs, prasugrel ko chahi, there is one ischemic stroke right? Especially in stroke, hemorrhagic stroke say this is less used, right? Okay, just remember prasugrel, this is very active drug, very potent drug. It acts quickly, but all at the expense of the more bleeding, right? So there is one contraindication, in fact, for prasugrel, that is stroke in which the ticlopidine and clopidogrel can be given, but prasugrel is contraindicated, right? So newer drugs we have, खाली नाममा दिन्छु अहिलेलाई, ticagrelor is for same group, and cangrelor is used parenteral. This is a parenteral preparation. All are used orally. Cangrelor is used mainly parenteral. Right. So these are the uses of the ATP receptor inhibitors. So stroke prevention with transient ischemic attacks or thrombotic stroke. Okay. Stroke prevention with transient ischemic attacks. You discuss what is transient ischemic attacks. You can say it is a mini stroke or any type of thrombotic stroke to prevent the further future stroke risk these are included in their medication, right? Here I want to mention again that prasugrel is contraindicated because of the higher risk of the bleeding, right? And can be also be used in intermittent claudication. Intermittent claudication is a type of peripheral arterial disease, right, or peripheral vascular disease, wherein you have like leg cramps or something, right, because of the decrease in blood circulation, right? So intermittent claudication, and to prevent thrombosis in patients undergoing placement of coronary stent. कोरोनरी स्टेन्टहरू भने बुझिन्छ है, यो स्टेन्टहरू राख्दाखेरि कोरोनरी आर्टरीमा एन्जियोप्लास्टी तिमीलाई थाहा छ है. सो एन्जियोप्लास्टी गर्दाखेरि स्टेन्टहरू राख्दाखेरि these drugs are given, right? And they are usually given along with the aspirin, right? And also in unstable angina, to prevent unstable angina, or of course it is a type of the coronary syndrome, acute coronary syndrome, right? Where it is a emergency condition again, of course, and here also clopidogrel is preferred, right? So all of them are clopidogrel is preferred, but remember prasugrel contraindication, okay, because of the better adverse effect profile, and combination with aspirin is superior to aspirin alone. And recent trend there is a trend called dual antiplatelet therapy. Aspirin is given along with clopidogrel or prasugrel, or even along with other antiplatelet drugs like the 2B3 receptor inhibitors or some of things, right? Okay, so 2B3 receptor antagonism we have. So this is 2B3 receptor this is I told you this is the last step, or you can say the final common pathway for platelet aggregation, isn't it? Sabai platelets aggregate garane bhaneko 2B3 receptor activation le garदाखेरि, right? So 2B3 receptor antagonist simply binds to the receptor and inhibits this final common pathway, right? And in fact, there is a disorder called Glanzmann's thrombasthenia, right? So this is a bleeding disorder, right? Wherein persons lacking this receptor, right? The 2B3 receptor antagonist receptor it's an inherited disorder, right? And that disorder is called Glanzmann's thrombasthenia. Right? Your receptor no patient, right? Your syndrome. Just for your knowledge, right? So abciximab is a fat fragment of the chimeric. It's a monoclonal antibody, right, against the 2B3 receptor, and it has been approved for use in this PCI, right, percutaneous coronary intervention. यसमा त्यही हो, angiography, angioplasty percutaneous coronary intervention, and also in acute coronary syndromes. All those the myocardial infarction or unstable angina, right? To prevent the further MI. Okay, and again, this is given along with aspirin and along with heparin. So adverse effects is of course mainly hemorrhage, right? Besides that, thrombocytopenia can occur, constipation, ileus, and arrhythmia are other adverse effects. Eptifibatide is a cyclic peptide inhibitor of the fibrinogen. Okay, binding site on this is a peptide. See, this is a monoclonal antibody. This is a peptide. Eptifibatide is a peptide, whereas tirofiban is a non-peptide inhibitor at the same receptor, right? This has a shorter duration of action, and hence because of that, it has to be used as continuous IV infusion, right? The action lasts only for a few hours after the stoppage of the infusion, immediately after the stoppage of infusion. Adverse effects similar to bleeding and thrombocytopenia. See, एकदम clearly the adverse effects confuse हुनु पर्दैन है. Aspirin को त थाहा नै छ तिमीलाई. Besides bleeding, of course, thrombocytopenia is another major adverse effect. Okay, sorry. Tirofiban, a non-peptide inhibitor, also has short duration of action and effective mainly in the MI and unstable angina. Okay. So trend drugs को use को trend side effects similar to those of epilepsy. So it's not there is okay. So just remember the name and mainly uses. Okay. यति मात्र हो drugs. So overall use of antiplatelet drugs हेर्नु पर्यो भने, so one thing I would like to repeat again, these are drugs. These drugs are used in arterial type of thrombi. But it can be the cerebral artery, it can be mainly the coronary arteries. So very easy. So coronary artery disease and then cerebral vascular disease. These are the main indications, right? So coronary artery disease, like the patients who have already got one infarction, right? So use of this drug will prevent the further repetition of the infarction, right? And even reduce the mortality rate. Acute coronary syndromes like unstable angina, use of drugs with unstable angina will reduce the risk of MI and sudden death in the future. Okay, so these are the coronary arterial diseases. These cerebral vascular diseases or the vessels in the brain, isn't it? So that will be the stroke mainly and transient ischemic attacks, right? So aspirin reduces mainly aspirin is used. It reduces the incidence of TIAs, of strokes in patients with TIAs and in those with history of stroke. So all these cerebrovascular diseases, right, or ischemic stroke or the angioplasty condition भयो, all those percutaneous coronary intervention angioplasty, angiography these are used. So mainly यसमा युज हुने भनेको aspirin हो, of course, along with either ticlopidine or clopidogrel. एकदम सिम्पल छ नि. Then prosthetic heart valves अहिलेलाई सिम्पल छ भन्नलाई हैन, तर the use is complicated, of course. Prosthetic heart valves and use of the valves, use of the prosthetic things, and then the arteriovenous shunts, again to prevent the formation of the platelet block formation. Antiplatelets can be used along with warfarin, right? And then venous thromboembolism. These are the secondary uses, of course, for antiplatelet drugs. And lastly, any type of other peripheral vascular disease like you discussed intermittent claudication, right? This can be used. Okay, these are the overall uses of the antiplatelet drugs. Second, say coronary arteries सम्झिने, cerebral vascular सम्झिने, and then all those angioplasties, stent placement सम्झिने. Okay, that's all. So lastly, this is actually a newer drug, silostazol drug. So I just want to mention here, this is a newer drug and it is basically a phosphodiesterase inhibitor, right? And it also promotes vasodilatation. We don't have much detail about this drug, right? But this has been used mainly to prevent the intermittent claudication. Actually, intermittent claudication, that peripheral vascular diseases. It's like a leg cramps, all right, because of the occlusion in the artery, basically mainly in the limbs, right? Mainly it's lower limbs, condition of intermittent claudication, right? It's like limping, like claudication, limping. right? This is the new